Now we will move to the last session. First talk by Dr. Biju John. Over to Dr. Biju John.
Good evening. Thank you all for coming and welcome to the weird and wonderful world of online CMEs and webinars. When Dr. Manjit George, the man who's been running tirelessly behind this conference, called me up and asked me to deliver a talk on ventilator troubleshooting, I asked him how many months did I have to finish the talk. When he said I had 20 minutes, I thought, one, he does not like me very much, and two, trying to empty an ocean with a teaspoon might be easier. My sense of doom turned to slight elation when he said that we would be focusing exclusively on the novice intensivist until I remembered my own days as a novice. In 1980, a very wise man called Hubert Dreyfus and his brother Stuart developed a model of skill acquisition, which later came to be called as a Dreyfus model. At the bottom rung of the ladder, we have the novice, who can be easily recognized by the fixed expression on his face. No one can make out whether he's excited or terrified, and his only priority in life is to get by without being called an idiot more than 10 times in a single day. His guiding principle in life is this: sometimes it is best to keep your mouth shut and be thought of as a fool rather than to open it and confirm it. After a while, the novice turns into the advanced beginner who can be recognized by the eagerness and enthusiasm he often expresses. In fact, eagerness and enthusiasm is what he should be protected from because he cannot recognize the mistakes he makes. He makes a lot of them and therefore needs constant supervision. The pupa one day turns into the butterfly, and the next stage is one of competence. Here you can be trusted to perform your task without supervision because at this stage you can recognize your own mistakes and correct them. You can also audit yourself and multitask to some extent. Above the stage of competence is a stage of expert. And as you can see, the ability to multitask grows manyfold. And he can also audit himself and others. The expert usually spends a significant part of his life concocting good-for-nothing guidelines and protocols, which no one in their right minds can adhere to. And above the stage of expert is the ethereal and rare stage of master, who has achieved a Zen-like state and has realized that it is not anything he or she does that results in a patient's recovery or death. He's humbled by the fact that most of everything he has learned so far is complete bullshit, and he tries in vain to tear down the system to rebuild it, and usually dies of depression when he realizes that it is an impossible task. In any discipline, the prevalence of these skill levels exhibits a bit of a worrying trend. As you can see, 60% of any team is made up of novices and advanced beginners. When the drama of COVID-19 exploded upon us 10 months ago, governments across the world were frantically trying to buy up ventilators because the so-called experts predicted an acute shortage in the availability of these machines. The question that kept me awake at night was this: who on earth is going to be operating all these machines, which can kill just as quickly as they help? The fact that the sickest patients are going to be looked after by the most inexperienced team members should be enough to make everyone wear masks and practice physical distancing for the rest of their lives. It did not help at all that anybody who knew how to handle a wrench and a hammer was busy making new ventilators and marketing them aggressively. The impressive list of new ventilator manufacturers included Mahindra & Mahindra, Maruti Motors, Kirloskar, and Bhaskara Industries from Kunnamkulam. I mean no disrespect to Kunnamkulam, it is a lovely town. Oh, I've digressed enough, back to the topic in hand. For most people, ventilator troubleshooting is about managing ventilator alarms and effectively silencing them without killing your patient or taking a hammer to the ventilator. At 2 o'clock in the morning, which is that unholy hour when hell breaks loose in most ICUs, when you're sleep deprived and the alarms drive you nuts, it's important to remember that these alarms are there for a reason, and you have to curb the instinct to automatically silence them. The patient at the end of the ventilator is the final piece in a long list of moving parts that make up a chain. Any chain is only as strong as its weakest link, and a problem in any of the moving parts can trigger a safety alarm. So effectively dealing with any alarm would involve a systematic checking of the chain for the weak links. Our primary concern is always the safety of the patient, and therefore this process should always start with a quick clinical examination of the patient. We're not here to treat a waveform on the monitor or a number on the ventilator. As a novice, I would urge you to completely forget what the ventilator is doing for the first couple of minutes and focus on the patient connected to it. Has this patient had a recent nursing intervention like an oral care or change of positioning? Does he or she look adequately sedated and pain-free? Or is it a case of inadequate sedation and therefore agitation and tachypnea? Is it a case of air hunger and increased work of breathing? Is he or she biting on the tube? Does the chest look like it's moving adequately? Do I want to confirm that there is bilaterally equal air entry by auscultating the chest? What are the vitals doing? Is it sudden hypoxemia, hypotension, tachycardia, or a combination of all three? Has there been a rapid deterioration of blood gases? And now would be a good time to see what the ventilator is doing and why it's upset. If one cannot identify the problem and therefore find a solution in the first minute, the conventional teaching was always to disconnect the patient from the ventilator and use a manual bagging circuit in an attempt to divorce the patient from the long chain of moving parts we mentioned, and just focus on the issues at the patient's end. One could gather useful information regarding resistance of the airways and even compliance of the lungs. These days, as the world has gone bloody mental over the COVID-19 pandemic, one has to be aware of the risks of potential aerosolization that could happen from breaking the circuit and manually bagging the patient. Various measures to prevent this has been described by the various agencies, unleashing a diarrhea of advice almost on a daily basis. I would urge you to follow your institutional protocols in this regard. Anytime I respond to an urgent call from a nurse to see a patient in ICU, the first thought that goes off my mind is this: is this patient going to die in the next 10 minutes? If I can rule that out, I have time to make myself a coffee and think. The life of every novice depends on mnemonics, and a useful checklist to go through your mind as you approach a ventilated patient is DOPES, DOPES, as is shown in this slide. It lists the most common conditions that can cause your patient to die in the next 10 minutes. There are a few alarms that the novice should be aware of. The absolute bane of every ICU is the high pressure alarm on the ventilator going off. Now, there are three components that make up the airway pressure measured by the ventilator. There is a resistive component offered by the flow of gases through the airways, an elastic component offered by the compliance of the alveoli, and an extra component offered by the set beep. Accordingly, you can have conditions causing increased resistance, conditions causing decreased compliance, and even dynamic pulmonary hyperinflation caused by auto beep, adding on to the set beep, especially in combination with increased respiratory rate and narrowed airways. Now, the key maneuver for separating out the rest of the etiologies of high peak pressures is the inspiratory pause or hold. Now, this is only in the setting of invasive ventilation, such as SS control or volume control mode. Pressing this button once will initiate an automatic ventilator seal of breathing circuit for about 2 seconds to stabilize the pressure measurement. It will not harm the patient. Its purpose is to differentiate if the high pressure is a compliance problem or a resistance problem by taking flow out of the equation. Now, the airway pressure is only looking at the pressure of the lung alveoli system, otherwise known as the plateau pressure. So a high peak pressure with a high P plat means that the compliance is low, which is a lung problem, like atrial cases, and a high peak pressure with a low P plat means there's a resistance component in the circuit, like bronchoconstriction, edema, in COPD or asthma. You have to remember, though, that the plateau pressure is only directly linked to the barotrauma in a remote way, because the true distending pressure of the alveolus is the transpulmonary pressure and nothing else. Nevertheless, it is not a good idea to run anybody on a consistently high plateau pressure. Now, a low exhaled tidal volume alarm may represent either a leak or a problem with the sensor. The commonest site of a leak is the endotracheal tube cuff, and it's quite easy to correct after checking with the cuff later. If the cuff is truly blown, then it might warrant a tube change. A low tidal volume alarm can also happen with pressure control mode, when some ventilators will stop delivery of flow when a high pressure alarm is activated. On the other hand, a high minute volume alarm can be caused by a nebulizer circuit adding its own volume to the measured volume, making the sensor go nuts. That's something you have to keep in mind. As a novice, your overwhelming instinct, particularly on a night shift, would be to maintain status quo just to avoid being called an idiot during the morning runs. But it is no excuse to be trigger happy where sedation and neuromuscular blockade is concerned. Always remember that a tachypnic patient on assist control or spontaneous breathing mode with acceptable vitals can be talked down without resorting to sedatives. On the other hand, one should not forget that a hypertensive and hypoxic patient who is also tachypnic is an acute left ventricular failure unless otherwise proven, especially if after there has been a reduction attempted in PEEP levels. A lot of valuable information can be gleaned in a very short time if you're familiar with the various ventilator waveforms, but that is a long discussion for another day after you've become advanced beginners. I shall wait patiently for that sunny day. The lay public might ascribe mythical and magical powers to the mechanical ventilator, but any ventilator is only as clever as the idiot who operates it. The wisest physician is often the one who knows when to step back from the patient's side and say, there is nothing more I can do here. That's all I wanted to tell you. Enjoy the rest of the evening, and I shall leave you with this piece of advice. Thank you very much.
Thank you, Dr. Biju John. Next, we have Dr. Vijeshri. Over to Dr. Vijeshri.
Good evening, friends. At the outset, let me thank the organizers for giving me an opportunity to talk to you regarding prone ventilation. Invasive mechanical ventilation is traditionally delivered with the patient in the supine position. Prone ventilation is ventilation that is delivered with the patient lying prone with his face and the front part of his torso facing downwards. Now, prone ventilation of ARDS patients is used as a rescue strategy to improve oxygenation. Why and how we do that, and what is the evidence for the same, shall be the basis of my talk over the next 15 minutes. Prone ventilation was proposed by Dr. A.C. Bryan, who is the inventor of the HFOV device, and he suggested that we should try prone positioning in children with acute respiratory failure who are still hypoxemic using the HFOV device. He anticipated an improvement in the oxygenation from the reaeration of the dorsal lung regions, which would no longer be compressed by the gravity as well as the abdominal contents. Now, how does prone ventilation work? Now, there are different models of the lung which have been explained, and we'll go to them one by one. Now, this is the sponge model of the lung. If you take a wet sponge and keep it in either the horizontal or vertical position, the water can be seen draining into the dependent areas. This effect is augmented by gravity. In ARDS, due to the endothelial dysfunction, there is accumulation of fluid within the alveoli, which tends to squeeze the gas out of these alveoli. The lung can be compared to the sponge with edema fluid collecting in the gravity-dependent dorsal regions as shown in this picture. In the prone position, the lung densities migrate to the ventral portion of the lung and the dorsal alveoli get recruited and thus improves the oxygenation. This model also helps in explaining the beneficial effect of applying PEEP, which acts as a counter pressure to the compressing effect of the weight of the lung fluid. Next is the slinky toy effect. The lungs can be imagined as a triangle slinky toy. Now, if you look at the picture on the left, if you suspend the slinky toy from the apex, we can see that the weight of the coils of the spring gathers at the bottom. If you suspend it from the broader base, as shown on the right side of the picture, we can see an even distribution of the weight between the coils. Now, this can be extrapolated to the lung. In the supine position, there is higher strain and larger variation in the distribution of alveolar sizes due to the effects of gravity and a steeper stress production during mechanical inspiration in the upper lung regions. In contrast, the prone position produces a more even strain and a more homogeneous distribution of alveolar size that lessens the inhomogeneity in stress development throughout the lungs during the mechanical inspiration. The next model that I would like to discuss is the shape matching model. The isolated lung that is shown in the left-hand side of the screen has a conical shape with the dependent side being much bigger than the non-dependent side in the supine position. On the other hand, the chest wall is a large cylindrical shape, and the problem that is seen is the shape matching problem. This is like fitting an elastic cone into a rigid cylinder. Now, because the two structures have the same volume, the lung must expand in its upper regions more than its lower ones, and this condition results to a greater expansion of the non-dependent alveolar units, or otherwise a lesser expansion of the dependent ones. When gravity is added to the mix, we can see that the dorsal alveoli get further compressed and less ventilated. Blood flow is more in the dorsal regions, and hence the blood is diverted to the lesser ventilated dorsal regions, leading to the ventilation perfusion mismatch. Now, if you prone these patients, as shown on the right-hand side of the picture, you can see that the dorsal area gets recruited within a few minutes, and the ventral lung alveoli get compressed due to the effect of gravity. However, this is opposed by the shape matching effect that takes place. However, if you note, the blood flow is still more in the dorsal region, and this is a universal fact. So there is a better ventilation perfusion matching when you put the patient in a prone position. So this can be summarized like if the patient, an ARDS patient, is in a supine position, you can see that the shape matching gravity as well as the superimposed pressure all act in the same direction, causing detrimental effect to the dependent alveoli. Whereas when the patient is prone, what happens is the shape matching counteracts the detrimental effect caused by the effects of gravity and superimposed pressure on the dorsal alveoli. Also, we can see that in the supine position, the heart tends to rest on the dorsal region of the lung, especially the left lower lobe. It is said that it occupies almost 50% of the left lower lobe. It occupies, or rather it causes its weight on the 50% of the left lower lobe. However, if you prone these patients, it can be seen that the heart tends to rest on the sternum, thereby the compression of the dorsal regions are prevented. Also, the compression on the anterior region, or the ventral zones of the lung is very minimal. Coming to the effect of the intra-abdominal pressure, the changes in regional diaphragmatic motion occur at the prone position. Now, decreased intra-abdominal pressure in the prone position, thereby unloading the weight of the abdominal content, may reduce the cephalic displacement of the diaphragm and alter its position and motion compared with the supine position. Also, it can be seen that in the prone position, it would promote forward drainage of secretions towards the central airway. Thereby, you can facilitate the clearance of the secretion. And also, prone position is thought to limit both gastroesophageal reflux and the pooling of oropharyngeal secretions above the endotracheal tube cuff, thus limiting the microaspiration of infected secretions into the lower respiratory tract. Now, this slide shows a summary of the proposed mechanisms for prone response. And it can be seen that all these models that I've explained are showing you that there is an improved ventilation in the dorsal region, leading to an improved ventilation perfusion matching, and thereby it prevents hypoxemia, or rather it improves the PF ratio. So how to do a prone maneuver? It can be done either by automated devices like the rotoprone beds, or it can be done manually. In manual proning, you should have a good number of staff, at least 5 people, with one team leader. The team leader is the person who coordinates the movement of the patient. The persons in team, the staff at position 2 and 5 have a direct view of the ventilator as well as the monitor. So they have the additional responsibility of monitoring these and verbalizing any changes to the team. The person in position 3 has the responsibility for central line and the pumps, and the person in position 4 has the responsibility for the catheter. And if there are additional lines like an ECMO or the chest tubes, you can have additional staff members. So there are 8 steps for proning. The first step is to have proper adequate number of staff. Each one introduces himself, and then as each person is given a role, and his role is defined. Each person's role is defined. In step 2 is positioning of the patient. You can see that the anterior chest leads are removed. The person at the head end coordinates the entire activity. He gives guidance to the other members of the team, and the patient is laid flat in the center of the bed in a neutral position, and the arm closest to the ventilator is tucked underneath the buttock with the palm facing anteriorly, and pillows are placed in the front of the chest and the iliac crest region, and also along the shin. The next step is patient wrapping. Here what is done is a clean bed sheet is placed on top of the patient over the pillows, and the edges from the top and bottom bed sheets are rolled tightly together, thereby encasing the patient between the 2 sheets and keeping the pillows in the correct position. Here this is called the envelope maneuver. And in the 4th step is to make a horizontal move. The direction of the horizontal move should be away from the ventilator in the opposite direction to which the patient is to be turned. And the next step is to have a lateral turn. In the lateral turn, the person at the head end would maintain a tight grip on the only part that is exposed is the neck and the head of the patient. And the lateral turn is done with the staff on either side should adjust their hand positions on the rolled up sheets so that they have hold of the opposite edge when compared to the horizontal move. And in step 6, the proning is completed with on the call of the person at the head end, the rolled up sheet is pulled up from beneath the patient while the patient is carefully turned into prone position. Then the ECG electrodes are reattached and all the monitoring is re-established. We should ensure that the ETT, the endotracheal tube, is not kinked and that a carbon dioxide trace is still present on the capnograph. And step 7 is the proper positioning of the patient. The patient should be nursed at 30 degrees in the reverse lumbar position, and the position of both head and arms should be alternated every 2 to 4 hours. The step 8 is the post-proning care or the pressure care, and you should make sure that there is optimal positioning of the pillows. The pressure areas should be, so you should proper protocol, proper checklists. Proning using the automated bed, the rotoprone system. You wind up the patient, and then using a switch in the foot end of the bed can be tilted over into the prone position. The advantage is it doesn't require more people, but the disadvantage is that you can have a lot of, it's a very costly equipment. And to simplify the checklist, you can remember it as A, B, C, D, E, F, G of prone positioning, where A stands for attachments, B for bedding, C for catheters, D for the dependent regions, E for the endotracheal tube, F for the Foley's catheter, and G for the genitals. So all this should be checked. All these things should be checked before proning and after proning. Now, what are the effects of proning? The effects of proning are on gas exchange, on lung mechanics, on the stress and strain, as well as on the hemodynamics. But however, we will be going through what happens on the gas exchange. So what is the effect on oxygenation? According to the arterial blood gas changes after their proning, ARDS patients can be classified as responders or non-responders. PO2 responders are those who have a PF ratio which increases by at least 20% or by more than 20 millimeters of mercury. And these responders are further subdivided into non-persistent or persistent according to the stability of the positive effect of the prone position for 1 hour after returning to the supine position. And now coming to the effect on ventilation, a decrease in PaCO2 is what is expected. A decrease in PaCO2 is to the first pronation rather than an increase in the PF ratio is significantly associated with lung recruitability and a better outcome. PaCO2 responders are those whose PaCO2 decreases by more than 1 millimeters of mercury. In PaCO2 non-responders, the primary mechanism of PaO2 increase is the diversion of blood flow. In PaCO2 responders, the primary mechanism is greater dorsal recruitment in comparison to ventral derecruitment combined with reduced alveolar overinflation. So this is supposed to be one of the great things that has happened in mechanical ventilation. So what is the evidence for it? Now, if you look at all the major trials, if you look at the early trials, that is from Gattinoni from Italy, Guerin from France, Mancebo from Spain, and the Tacon and friends from, again, Italy, you can see that in all of these trials, oxygenation did improve, but there was no improvement in mortality. So what was the problem here? Here, prone positioning was used as a salvage therapy. It was done late and it did improve oxygenation, but there was no mortality difference. However, all of this changed in 2013 with the Perceiver trial where patients with severe ARDS were selected to undergo proning for at least 16 hours per day, and it was initiated early. Within 36 hours of initiation of mechanical ventilation, patients were proned. What did it show? It showed that the mortality reduced from 32.8% in the supine group to 16% in the prone group, more than 50% reduction in mortality. Also, the patients in the prone group or rather they had a lesser use of rescue therapy, like the use of ECMO and nitric oxide. So what happened here was the proning was done early and it was given for a long time. So it decreased the lung parenchymal heterogeneity and it decreased the extreme tissue strain, thereby prevented ventilation or ventilator-induced lung injury. Now, coming to the meta-analysis done on prone ventilation, we can see that most of these meta-analysis showed a survival benefit. If you look at the Sachin Sood meta-analysis of 2014, whenever the patient had protective lung ventilation, the forest plot definitely favored prone in terms of mortality. Similarly, if you had a prone duration of more than 16 hours, the mortality, the difference in mortality was seen in the prone group. Similarly, patients with severe and moderate hypoxemia who underwent prone ventilation, they also definitely had a better survival in the prone group. Coming to the latest meta-analysis published by Labina Munshi in 2017 in the Annals of American Thoracic Society, she found that she and her colleagues found that there was a mortality benefit in patients who underwent prone ventilation. And this was seen more if the patient had undergone lung protective ventilation, as well as if they have had a minimum of 12 hours of proning sessions. Also, if the patients were having moderate to severe ARDS. So they concluded that in patients with moderate to severe ARDS, if they had a longer duration of more than 12 hours of proning, definitely there was mortality benefit. However, in 2017, the Lung Safe trial, which was done, which was a prospective trial that was done over 450 ICUs spread across 50 countries in 5 different continents, shockingly, we realized that only less than 2/3 of our ARDS patients were getting protective lung ventilation. And what about prone ventilation? It was seen that only 16.3% of the severe ARDS patients received prone ventilation. And so this is not something which is good for a maneuver that can cause 50% reduction in mortality. So why is this prone position so unpopular? It is because the most common causes said is it is because it's difficult to initiate, burdensome to maintain, and can cause complications like pressure sores. So the main things are probably because of the lack of a coordinated proning protocol. It could be because of the unfamiliarity of the staff with the prone positioning technique, and the prevalence of staffing constraints and shortage of equipments. Now, coming to the contraindications are mainly the cervical spine instability, pregnancy, multiple fractures or trauma, especially for the pelvis and face, if there is a raised intracranial tension, and in case of hemodynamic instability. In the complications that are seen are nerve compression, the dislodgement of the endotracheal tube or the vascular catheters, retinal damage, pressure sores, and the unfortunate cardiac arrests that do occur in prone position. It might be easier to resuscitate somebody in supine position, but turning a critically ill prone patient in an emergency is associated with significant risk. So it is recommended that a two-handed technique for chest compression over the mid-thoracic spine located between the two scapula is done. Counter pressure may be applied using a second person. The defibrillator paddles are applied in a posterolateral approach, where the posterior paddle is placed over the right scapula and the lateral paddle is placed, pad is placed in the mid-axillary line in the left axilla. And this is the protocol for your prone CPR. You should always check, make sure that there is no ETT displacement in the position or the ventilator disconnection, which could be the cause of cardiac arrest. And if you find that it is not effective, make sure that you turn the patient supine and continue your CPR. Awake proning has been advocated in COVID-19. And what are the guidelines? What does the guidelines say of different societies? You can see that the American Thoracic Society published their guidelines in 2017. They recommended that adult patients with severe ARDS, they received prone positioning for more than 12 hours per day, and it was a grade 1 recommendation. What about the recommendations from the European Society of Intensive Care Medicine? They say that prone positioning should be used in ARDS with a PF ratio of less than 150 to reduce mortality, and sessions of at least 16 consecutive hours have been recommended, which is a grade 1 recommendation. And they have given their therapeutic algorithm for early ARDS management. And what about the UK Faculty of Intensive Care Medicine? They have published their guidelines in 2019, where they said that they recommend the use of prone positioning for at least 12 hours per day in moderate to severe ARDS. And again, it's a grade 1 recommendation. So summarizing, the prone position alters the mechanics and physiology of gas exchange to consistently result in improved oxygenation and may result in improved mortality in severe ARDS. For most patients with ARDS, we recommend using low tidal volume ventilation, the supine position, rather than prone ventilation as the initial ventilation strategy. For patients who fail this strategy and who have severe ARDS, we suggest a trial of prone ventilation, provided there are no contraindications. We have to implement the prone ventilation early in the course of ARDS, that is within the first 36 hours, and not as a rescue or a last-ditch effort. You have to maintain the prone position for at least 16 hours. And awake prone positioning is advocated during the COVID pandemic. Prone positioning is a relatively economical method of ARDS management. It might be a simple solution to the complicated problem of the high burden of ARDS and the high related mortality. Thank you very much.
Thank you, Dr. Vijish. Next, we have Dr. Sara Varghese. Over to Dr. Sara Varghese.
Warm greetings from MOSC Medical College. Thank you for the privilege of standing before you and presenting in ISAWEBCON Annual State Conference, Kerala. The topic that we are discussing today is fluid challenge in ICU. Let us start the discussion with a case. A 65-year-old patient who's a smoker with history of hypertension and COPD presents in the ER with a 1-day-old perforation peritonitis. His abdomen is tense and tender. He's got bilateral V's in his chest. He is tachycardic, tachypneic, hypotensive. ABG shows metabolic acidosis. Lactates are 4.5. 2 liters of ringer lactate are infused in the ER. When he reaches the ICU, another liter of ringer lactate is infused. A central line is inserted, which shows a CVP of 11. He's mechanically ventilated. Noradrenaline has been started, but he's still hypotensive and his heart rate is around 116 per minute. Acidosis is persisting and lactates are going up. Should we give more fluids to this patient? This is a question that we face. Fluid challenge is defined as a dynamic test of the cardiovascular system represented by administration of fluid bolus in a predetermined time interval to assess the preload status of the patient. We will be discussing this topic under the following headings. Why do we need to give a fluid challenge? When should we give it? And how do we do it? Fluid therapy started in the 1930s when Dr. Thomas Latte found that an infusion of salt water improved the condition of the cholera patients. We gradually started giving a mixture of nutrients to patients. We used IV fluids to maintain homeostasis. In the 21st century, we have come to the realization that fluids are also drugs with a therapeutic range. We should be as careful of prescribing fluids as we are with any other drug. So why do we give fluids in acute circulatory failure? The answer lies in the Frank-Starling curve. We know that in response to fluid boluses, if the patient is in the steep part of the Frank-Starling curve, the stroke volume increases and the cardiac output increases. But what we have to realize is that the Frank-Starling curve is not the same in between patients, and also in the same patient, it can vary according to the ventricular function. If the patient is on the flat part of the Frank-Starling curve, or if they have a decreased ventricular function, a fluid bolus with a small increase in cardiac output can cause very large increase in the extravascular lung water. So we are walking a tightrope between the lungs and the kidneys. We know that tissue hypovolemia can cause tissue hypoperfusion, organ dysfunction, and death. At the same time, hypervolemia can cause edema, prolonged ICU stay, and increase in mortality. On top of all this, only 50% of critically ill patients are fluid responsive. So the question is, will the cardiac output improve if I give more fluids? This is known as fluid responsiveness. That is a state where there is an increase in stroke volume and hence cardiac output after administration of fluid. Historically, we have measured fluid responsiveness with static indices, CVP being the commonest. Maybe because it is cheap, easy to measure, we need only minimal apparatus, and CVP values have a safety value. But recent analysis have, especially this one by Dr. Paul Emerick, has shown that the area under the curve for CVP is only 0.56 for fluid responsiveness. So this is not a good approach to fluid resuscitation and should be abandoned. The same opinion has been seen, we can see in the task force of the European Society of Intensive Care Medicine Surviving Sepsis campaign guidelines, which recommend using dynamic over static variables to predict fluid responsiveness when applicable. So what are the dynamic indices of fluid responsiveness? This can be either based on heart-lung interactions or based on measurements of flow. This in itself is a vast topic, so I'll be just mentioning the names of the commonly used ones. The stroke volume variation, the pulse pressure variability, which will predict fluid responsiveness in patients if their values are above a cutoff range. The KVL index is now very commonly used because ultrasound and the intensivist have a very close relationship now, and we do that quite routinely in our ICUs. But these indices also have certain limitations. The dynamic indices can be used only in patients who are being mechanically ventilated with a tidal volume of around 8 to 10 ml per kg. They should have a low heart rate to respiratory rate ratio. There should be no arrhythmias, and it is not reliable in patients with increased abdominal pressure or an open thorax, and the patient should not have spontaneous respiration. So the use of dynamic indices is being limited to a particular number of patients. So then comes the role of the functional hemodynamic test. This is a maneuver that affects the cardiac function with a subsequent hemodynamic response, of which fluid challenge is the gold standard. Fluid challenge is universally applied in most of the ICUs. So Fenici trial in 2015 looked at the practice of fluid challenge in the ICUs, multiple ICUs all over the world. What they found, they looked at around more than 2,000 patients, and they found that the volume infused varied from 250 mils to around a liter. The rate of infusion varied from 15 minutes to an hour. Crystalloids were mostly used. The triggers for fluid challenge commonly was hypotension or oliguria, and dynamic indices were used only in 22% of the ICUs. The systematic review of studies from 1994 to 2014, they found in that definite standards of fluid challenge do remain undefined, and there is widely varying practices in between ICUs. When Chasconi looked at the impact of the technique of fluid challenge on the diagnosis of fluid responsiveness, she also found that there is a widely varying practice, and in that, fluid challenge to be effective to predict fluid responsiveness, we should check the response within 15 minutes. This study also says that the standard technique is not available, and it should be it is desirable. So when should we give the fluid challenge? The Rose concept of fluid therapy is practiced now. We know that during the resuscitation phase, the patient requires fluids. So there is no need to do a fluid challenge. Give fluids when you see the patient immediately till you should give it as fast as possible. Don't waste time doing a fluid challenge. But during the second hit of shock, that is we've resuscitated a little bit, but the patient still remains in acute circulatory failure. We don't know whether the patient will improve if we give more fluids or not. That is the optimization phase. During this phase comes the role of fluid challenge. We need to support the organs and improve tissue perfusion, and there should be no major contraindications for fluids. At this point of time, we should do the fluid challenge. So how do we do this? The Troll mnemonic is a safe way of doing fluid challenge recommended by Vincent Whale. The T is type of fluid we should define. Rate of fluid administration should be checked. There should be clear-cut objectives to what we are trying to achieve with the fluid challenge, and we should keep limits, safety limits, so that we can stop it before harming the patient. So 200 to 500 ml of crystalloid bolus is a good volume for doing a fluid challenge. It should be transfused within 10 to 15 minutes, and we should assess the response to the fluid challenge within 15 minutes. To assess the fluid challenge, we should use minimally invasive or non-invasive cardiac output monitor. A change in stroke volume of more than 10% is significant and predicts fluid responsiveness. We should keep the safety limit that if the stroke volume is less than 10%, don't transfuse more fluids. And during the transfusion of fluid challenge itself, check whether the patient is going into overload by using an ultrasound probe or even a stethoscope to look for crepitations. The same fluid challenge, if we give multiple times in a day, around 500 ml multiple times in a day, can in itself cause hypervolemia. So Muller et al. Has devised the mini fluid challenge. 100 ml of fluid is given fast over 1 to 2 minutes, and then a more than 5% increase in stroke volume predicted fluid responsiveness. This has a good area under the curve, and it has been validated by multiple studies in ICU and OR, but it requires a transthoracic echo to measure the aortic velocity time integral. It has to be measured really fast, and the specificity is only around 78%. So is there a way to do a fluid challenge without fluid? Professor Tubul and team devised the passive leg raising. This was being used in cardiac resuscitation during hypovolemic shock, but they used this to predict fluid responsiveness. It is a simple and reversible technique where we get around 300 ml of blood as preload, and passive leg raising is reliable in conditions in which dynamic indices cannot be used. We have to start from a semi-recumbent position, make sure that we are using real-time cardiac output monitoring, and we have to measure the cardiac output within 30 to 90 seconds of doing the PLR. And we have to remember that the bed has to be lifted, not the legs of the patient, because the patient has to be calm, pain-free, so that the sympathetic effect does not affect the test. So how do we do it? The patient is kept semi-recumbent, measure the cardiac output, then use the bed adjustment to lift the legs up, assess the cardiac output again, reassess put back the patient into semi-recumbent position, reassess the cardiac output, and it should return to the baseline. If this happens, the patient is volume responsive, and we can load the patient with more fluids. A variability of more than 10% of cardiac output is predicts fluid responsiveness. But PLR is unreliable in severely hypovolemic patients. It requires continuous cardiac output monitoring. It cannot be used in patients with intra-abdominal hypertension, raised ICP, or if they are in a condition where the position cannot be changed. Another test which can be used is the end expiratory occlusion test. This is also devised by Dr. Tubul and team, which is quite smart. They did an end expiratory hold for 15 seconds. This prevents the cyclic impediment of venous return and increases the preload. If the cardiac output increases by more than 5%, this is significant. The ease of execution is very good. This test can be used in low tidal volume, high PEEP ventilation. That is, our ARDS patients also we can use this, but it cannot be used in spontaneously breathing and non-intubated patients, and this requires a precise and accurate cardiac output monitor. These are some reviews of the end expiratory occlusion test, and but it has been found not to be useful in laparotomic surgeries. So we were talking about fluid challenge, and in conclusion, I would like to say that fluid challenge should be done with a standardized protocol. It should be done only in patients with acute circulatory failure in the optimization phase. Monitor the response with dynamic parameters of cardiac output. Passive leg raising can be used in most situations, and always remember, no test is perfect. Integrate dynamic indices and clinical assessment to guide your fluid therapy. Thank you for your attention.
Thank you, Dr. Sarah. Now the panel is open for discussion.
I request, good evening all. I request Dr. Balabhaskar to start the discussion. Balabhaskar sir, please.
Yeah, thank you. I just listened to Dr. Vijesh and Dr. Sarah, the half of first speaker's presentation. Dr. Vijesh, just wanted to know, because we have become more interested in prone ventilation now because of the COVID season. That's one thing. Problem is basically initially it is awake prone, which was popularized a lot, and you very neatly talked about A to G steps related to proning. But one thing, even in practice, because I have been active in the COVID management, the manpower availability. So, for example, it should be A to Z plus M also. Because your illustrations were very good and many people were doing it together. So that has been one limitation I felt. Of course, the basic prone position problems related to the immune system, the respiratory system, and the pressure point to be protected, all of them are, yes, standard discussions. But manpower problems is one which is very difficult in COVID conditions, because it is not just using physical strength and turning the position. We are talking about self-protection or medical personnel. That is one, I think, is very important in COVID times. Second thing is, basically I found is, yes, we do talk about awake proning, but the compliance from the patients has been very limited. Awake proning. We have got, for example, about 30 patients in the ICU, and if we have about 20 patients who are awake, not on invasive ventilation, and of course not on a very high level of non-invasive ventilation also, it is very difficult to get them to turn prone. I find probably about 20% of the patients, awake patients, cooperate, but rest of the 80% don't cooperate for awake proning. Is it not a significant percentage for us to, because if it is benefiting 20 out of 100 patients, awake patients, what is the use of talking about the benefits of prone ventilation?
And correct, sir. In COVID situation, since it's awake, it's very difficult to lie prone. Yeah. So they are suggesting that we have to change positions. Probably every 2 hours, we have to change the positions, lie on the lateral position, and then go back to prone. So, as you said, sir, it's really difficult for an awake patient to lie prone for a longer time. And regarding the manpower, absolutely right. We should have at least 5 people for doing a successful proning maneuver. And if the patient has chest tubes or even an ECMO line, you need more people.
Yeah. And secondly, taking it a little bit further, sir, you want to come in, Dr. Mishra?
Yes, I would like to make a comment in this respect.
Yes, sir.
I think I'm audible. I'm very sorry. I joined bit late because I was not very sure as to what session I have to be. And somehow thanks to Dr. Venkat. About your question. Yes, I'm very happy that Dr. Vijay talked in very details about the prone positioning in ARDS. But we wanted him to highlight more about our experiences and experiences of others in COVID patients. And there have been a lot of experiences on prone position on COVID patients, awake more, invasive ventilation less. We have learned that NIV is probably the best way of managing these patients until we can manage, and invasive ventilation comes at later stage. Now that with experience we have learned this, and everyone agrees about this, and there is a lot of patient load in Ordinary Institute of Medical Sciences, and one of these conferences they had contributed their experiences on prone positioning in COVID patients, and they have given a lot many good insight into all this. I would have liked Dr. Vijay to talk more, to give at least some studies on COVID patients. He mentioned in the end 2-3 studies, but they all were on ARDS patients in non-COVID patients. So, and coming to Dr. Balabhaskar, actually, there is a lot advantage of prone position, even though not all awake patients cooperate. Yes, not all cooperate, yes, but many cooperate. Maybe 20% in your case, probably 35, 40%, or probably 50%. I will say 100% in our situation, in our hospital. We instruct them, explain them, and after explaining and seeking their cooperation, they do cooperate. They may not continue being prone for a very long period. They sometimes tell us to change, and we do that. And then again, after some time, we go back to prone. We don't have a lot of patients with us, but our center is also a fully COVID institute in our district. So we have a couple of patients whom we have done COVID patients, prone positions. Actually, what is very important is it is very difficult to get 5-6 persons who will touch these patients and will help us in proning if they are on invasive ventilation. So patients on invasive ventilation is difficult to make him prone safely and do the keep them in prone position. Awake, we don't need so many patients. If patient cooperates, probably 2 or 3 of us are enough. Probably the treating physician is enough. So he cooperates and he goes back, and we have to just manage the mask or whatever means of ventilation we are doing. Usually, NIV ventilated patients are very cooperative, and it is easier to put them into prone position. And in fact, we don't need anybody other than this treating nurse and maybe a resident doctor, if present, can do this job very well. So this is the logistic that prone in awake patients should always be tried whenever it is required, rather than quickly going into invasive ventilation and in fact complicating the issue. Because invasive ventilation managing for longer period in most hospitals is very difficult. So, and proning also is more difficult. So this is what I thought I should put, Dr. Bala. So I believe whatever patients agree, we should try.
Thank you, sir. It's a very nice perspective. Yes, from your point of view, with respect to the actual practical difficulties which we face. But obesity and proning, and what about the perfusion-related matters, Dr. Videsh? Because we are only, of course, talking about the advantages of many areas, collapsed areas opening, non-ventilated lungs being ventilated nicely.
There is absolutely no change in the perfusion matter when you prone the patient. The perfusion still is maintained in the perfusion is still in the same way as the patient was in the supine position. The perfusion goes maximum to the dorsal area itself. So the advantage of proning is you get a better ventilation perfusion matching, because the dorsal areas get recruited, and the ventral re-recruitment is usually prevented by the the de-recruitment of the ventral areas are prevented by the shape matching model of the lung.
The reason I just asked was, again, sorry, in a sense, we are all tending to ask more towards the COVID-related ARDS. Probably we call it as cards nowadays than COVID ARDS, because there have been isolated publications of cases related to proning in intubated patients of COVID also. The reason I asked that particular question was there was a change in the perfusion in specific areas of the lungs, which was obtained by impedance tomography in one published article, wherein they talked about increase in perfusion and which was associated with decrease in the ventilation in certain areas of the lungs. In that particular patients who had more of a ground glass appearance than actual physical damage which was localized to some areas of the lung. Because when we talk about ARDS and we talk about uniform ground glass appearance, and if we talk about prone ventilation, there is a good discussion. But if there is specific lung damage, we are seeing different types of lung damages in COVID. So if it is not a ground glass appearance, it is multiple areas of pneumonia, pneumonic patches, totally unventilated areas. Probably perfusion is also a problem because we talk about thrombosed parts of the pulmonary circulation. That is the reason probably perfusion should be specifically investigated in COVID patients when we talk about prone ventilation. So that's the way I just wanted to convey to you, basically. So thank you, Vijay. Thanks for that nice presentation.
Thank you, sir.
And with respect to Dr. Sara, yes, as you say, the mini challenge has been the one which has been very important nowadays, mini fluid challenge. Only thing is, it is the effects are transient and should be responding to assessment of the cardiac output very early. But what is ultimately more important when we talk about fluid challenge is, yes, we want an endpoint where oxygen delivery to the tissues becomes more optimized. That's the endpoint is that we don't want hypoxia at the tissue level because this has been necessitated due to some circulatory compromise in the patient. Very simple questions in the sense, which fluid do we insist upon? Is it normal saline? Is it Hartmann solution? Just for the benefit of
balanced salt solution is advised now.
Yeah.
The previous studies used colloids also, but now colloids are not recommended. Balanced salt solution and Hartmann solution if there is no contraindication for lactates. Bringer lactate if there is no contraindication for lactate included, or even plasmolite can be given as the fluid challenge.
Okay, so basically you are talking about crystalloids. We are
Yes.
not talking about lactated solution if there is no contraindication. We are not talking about 5% dextrose. Balanced salt solutions could be Hartmann solution or it could be normal saline for the patient. So ultimately, what could be the goal direction? Is it just based upon the CVP or the hemodynamic parameters obtained from an echocardiography or a pulmonary artery catheter with respect to the stroke volume, cardiac output?
Minimally invasive cardiac output monitor is recommended in the sense if we have a LITCO or a PICO, that would be ideal. But I wonder how many places have that routinely and available in all patients who require a fluid challenge. So we'll have to use some other parameters also. The recommended ones are the dynamic parameters of fluid responsiveness or cardiac output. Stroke volume should be measured. But in situations where it is resource limited, CVP in a way can be used because CVP values in serial has been shown to predict fluid responsiveness. Low values like less than 6 is good enough. I mean, if it is less than 6, if you can give more fluid, and if a cutoff of more than 12 or 12 to 14 again is a safety limit, we shouldn't give more fluids beyond that. That kind of parameter, that kind of cutoffs can be used for CVP. But ideally, dynamic parameters of cardiac output and stroke volume should be used.
Yeah, the basic definition and the procedure is based upon at least some of these minimally invasive assessment techniques like ITCO. Any positional considerations with respect to the challenge part?
The passive leg raising, sir?
No, the actual position of the patient at the time of testing.
At the time of testing, the patient should be ideally supine, but head up 30 degrees is acceptable. Other than that, not much of difference, sir.
The reason I am asking is, yes, if we are trying to talk about the fluid responsiveness in a patient who is hemodynamically compromised. So is it advised? Of course, yes, this is the perfect position. For discussion purpose, is it possible to have the patient to be laid supine or head and up or head and down? Because it can have implications on the existing hemodynamic parameters. So that's the reason I asked.
Yes, sir, but
Yeah.
ideally, I mean, when you're giving a fluid challenge, better to put them on supine, maybe for that duration of time. Always there is the limitation that in patients with severe ARDS, with low tidal volume ventilation, this might not be effective.
Okay.
Dr. Bala.
Yes, sir. Please come in, sir.
Sarah, please do not mind my comment.
No, sir.
In a CME brief lecture like this, it will be better if you just give gist of what is the principle of fluid management in this situation. And then you may give 2, 3, 4, couple of, I'm sorry, my grandson is not ready. Then you should give a couple of case scenarios, you see. Then probably it gives more information and more, more useful information to the audience.
Yes.
I mean, you may try this sometime later, then you may find the difference.
Yeah.
Thank you so much. Thank you.
Thank you, sir.
Thank you. Dr. Vishwanath is there?
Yeah.
Yeah, no, sir. Dr. Vishwanath, one of our colleagues. Vishwanath Hiramat. So is he muted?
Hello.
No, we can unmute him. And Dr. Sajesh is also there.
Sajesh?
Sir, according to our plan, the validatory function will be on KPR Hall. So we have to log out from our Zoom login and log in through the other login.
What is the time, please?
7:35. We can log out from here and come there. 2-3 minutes, you can finish. Yeah.
Thank you. Thank you. Seeing you all. Thank you, Balabhaskar. Seeing you after a long time.
Thank you. It was a nice presentation by the team of.
Balabhaskar, give the concluding remarks.
Thank you. Because the session was actually extremely nicely, I mean, the topic was chosen very nicely. It could have been apt to use this session probably in the early morning session also, basically because all the three topics are very practical during these times where we are there as COVID warriors through and through. Some of our young anesthesiologists in periphery and within the medical colleges, basically, yes, they must be knowing about, they were exposed, but they were overwhelmed by the exposure to critical care now. So the first topic about the basics of how somebody should be operating and troubleshooting a ventilator has been aptly chosen. The second one is about the prone ventilation, yes, extremely most important. And the third one is fluid challenge.
Forward.
Muted. Yeah. So suddenly I was muted. So just to recapture, what I was trying to suggest was the session was very good in terms of the choice of three topics here. Very apt for this COVID season also. Number one. Number two is many of the anesthesiologists have not been exposed to COVID. And this is the first one basically about troubleshooting. Second one about the prone positioning, and the third one about the fluid challenges. And all of these are spoken extremely nicely within the limited time. Thank you very much, and I hand over to Dr. Venkatagiri and Dr. Binil. Thank you.
Thank you so much.
Thank you.
Venkat has to say anything. Yes, Venkat.
Dr. Giri?
Something.
Venkat Giri, we are waiting for you to say something. Goodbye or something.
Venkatgiri has nothing to speak. You are the speakers. I am the
Okay.
host. You are the guest. So I will speak after 1 year.
We are family members. Thank you. Thank you so much.
Thank you so much, sir, for your kind
Vijesh,
time
nice
and
talk.
this thing attending here. And last minute, my request to chair. You have done that. Excellent. Panditji, really indebted to you.
Thank you. Thank you.
Sajesh can tell his experience. He was there in Mumbai and he went with the ISA mission to Mumbai. Maybe 1 or 2 minutes, Sajesh can tell that before we go to the other hall.
Oh, yes.
Yeah,
Mumbai experience.
I was muted. And now only I allowed to speak. The technical reasons, maybe because of this. And two comments on that, on regarding the prawn position ventilation and all. Bala, what Bala said is exactly right. That this is because it's some HR, the manpower in repositioning and all in the COVID scenario. It's very, very difficult in the COVID ICU. Getting a manpower for prawn positions at least for 12 hours in a day. It's very difficult. But in a selected cases, we do actually. That is found to be effective. It should be effective because any ARDS it should be effective and all. COVID is nothing but anything else. But the thing is that in the awake cases also, awake, that means patient with severe hypoxemia and all, the awake prawning also has got a very good role in COVID management. And what we do is that it's a CARP. Actually, the COVID airway repositioning prawning protocol. That's a CARP actually. That every 2 hours we can change the position, left lateral position, right lateral position, so sitting with 30 to 90 degree sitting, then prawning, of course. But here also the major problem with this, patients are very reluctant to prawn. Especially we know that the most important comorbidity which is affecting the COVID, when dangerous to COVID is morbidity. It's severe morbidity, severe morbidity actually. Actually this is obesity. Severe obesity is the major morbidity issue. So then severe obese patients, very difficult for them to keep in dyspnea and distress and keep in the prawn positions. But normally what we feel is that in the CARP positioning, CARP protocol positioning, they will adopt some left lateral position or right lateral position, whichever. Even we can evidence that the saturation wise it will be better, but patient's point of view, they will adopt in some position. Left lateral, they will adopt, and right lateral, they adopt. Some patients even adopt in the prawn position. We properly explain to them and all. That is very useful in that situations and all. Another point is the Biju John and all is there, but we don't have sufficient time. But we have to discuss a little more on the ARDS on the L phenotype and S phenotype of the COVID. In classical COVID, ARDS COVID, we will get in a very selected patients only. That's a H phenotype. Most of them will be in a L phenotype position. The management also is a little difficult. Not difficult, different from the classical, as Bala said, cards. But these are the two things I want to just add on that. Anyway, nice presentations. Thank you all. We are moving to the conference, the other major session, so I am not taking much time. Okay, thank you.
Thank you all. Valedictory is about to start in KPR Hall. Please move to KPR Hall. Thank you all.
Thank you. Thank you. Good night. Thank you. KPR.